Just ahead on Being Well, RN and diabetes educator Paula Enstrom from Sarah Bush Lincoln Health System is here to talk to us about diabetes. We'll learn more about how it's diagnosed and the long-term effects that it can cause, especially if left untreated. Paula will walk us through the education process for newly diagnosed patients and let us know about some new medications on the horizon. That's all next, so don't go away. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255. Rediscover Paris. Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center. Hello, and thanks for joining us for Being Well. I'm your host, Lori Banks, and today Paula Enstrom from Sarah Bush Lincoln Health System is here to talk to us about diabetes, in particular type 2 diabetes. Paula, tell us a little bit about what you do.
I'm a diabetic educator, and I meet with people who have either been newly diagnosed with diabetes or are having issues managing their diabetes. Find out where they are with that, and then we get them enrolled in a program called Living with Diabetes. It's an exercise and education program. We help them learn all about their particular diabetes, because everyone's a little different, and how to manage it.
All right, so what is the difference between type 1 and type 2? Let's establish that first.
Okay. Type 1 diabetes is an autoimmune disease. We used to call it juvenile diabetes because we normally see it in children and young adults. And what happens is, for some reason, like many autoimmune diseases, the body attacks certain cells, and it attacks the beta cells that make insulin, and so they stop making insulin. And in order to live, they have to take insulin the rest of their life. Type 2 diabetes is kind of a different beast. They both have some genetic factors to them. They run in families, but with type 2 diabetes, inactivity, weight, genetics, all play into that. And basically what happens over time is that the cells become unresponsive to insulin. They respond less and less to it, and so blood sugars start to go up. And some other things are going on. The body stops making as much insulin over time, and also the liver sends out glucose at inappropriate times. It's supposed to store energy for us and send it out when we need it, when we're getting low. And it sends it out when they eat, which is very inappropriate. And so they have a very hard time managing that.
So what exactly does insulin do? What's its job?
Insulin is a hormone that helps us take the energy from the carbohydrates that we eat, which turn to sugar, and helps us to use that for energy, for muscle contraction, for all our bodily functions.
So it's pretty essential.
It's very essential.
So how would someone know if they have diabetes, have type 2?
Well, if they go to their doctor regularly, hopefully there's screening for that. Normally a fasting blood sugar test would be done, or they can do an average 3-month blood sugar test called hemoglobin A1C. And if those are a little elevated, they may be pre-diabetic. There's specific guidelines for that, and if they're elevated more, then they're considered diabetic. If they don't go to the doctor, they're not going to know until they've had it for a long time. And that's a very scary prospect, because the longer you have diabetes and the more poorly it's controlled, the higher your risk of complications. So if I'm going around like many people do, knowing it's in my family, pretty sure I have it, but not wanting to know, that whole time I have it, when I don't know I have it for sure and I'm not doing anything about it, it's damaging me.
And you had said something interesting, that sometimes you can note changes in people 5 years before they're actually diagnosed with pre-diabetes. There are things going on.
You start to develop some insulin resistance, and we know that a lot of people with insulin resistance gain belly weight, which causes the cells to respond to insulin less. So when people start to put on a lot of excess weight in the belly, and when they're inactive, because that also desensitizes the cells to insulin, they're much more likely to be starting into that phase of going to be going into prediabetes. Because basically what's happening when your cells don't respond to insulin as well, your body starts to make extra ones.
Okay.
And then over time, your body gets tired of working overtime, just like you and I do. And the cells that make the insulin start to wear out. And when they start to wear out some with that insulin resistance, that's when you're pre-diabetic. And when they wear out even more with that insulin resistance, that's when you're diabetic. But to clarify, not everybody who gains weight in the middle will become diabetic.
Okay. Can you talk about glucose numbers? What is considered normal? What's pre-diabetic and what's diabetic?
Sure. Fasting blood sugar, less than 100, they usually say 60 or 65, depending on the lab, to 99 is in the normal range. A fasting blood sugar test of 100 to 125 on 2 or more occasions is pre-diabetic. And a fasting blood sugar of 126 or higher 2 or more times is diabetic.
Okay, so important numbers to remember. You should know those, and you should know your blood pressure as well. Are those numbers, blood pressure numbers, what was considered normal, that number keeps going down? Is that happening with blood sugar levels or not?
With blood sugar levels, it has gone down. When I first started in nursing back in ancient times, the numbers were around 150 to diagnose diabetes.
Okay.
But what they found is that a lot of people, before they ever were diagnosed, had complications and problems. And that's how they're finding that they had it. And so they've lowered that criteria over time to try to capture people early enough to help prevent those complications.
All right. So if someone out there is watching and they're newly diagnosed, they're going to be barraged with a whole bunch of lifestyle changes and terminology. You as a diabetic educator, how do you kind of run someone through the process of, their diagnosis? It's a lot.
It is. It depends on the person, it really does, and where they're at, because some people are not ready to hear hardly anything, and some people are just sponges wanting as much information as possible. And you really have to be aware of that and pay attention to that, because if you approach it in the wrong way, people may not come back. But basically I explained that their metabolism has changed, their body is not using carbohydrates for energy the way it should, that they still need to eat those things, but we just have to moderate it now to help them. That it used to be that their body, no matter what they did, whether it was a huge banana split or a celery stick, it would keep your blood sugar nice and steady, and now it can't do that. And so instead, we have to be very consistent about how much they eat and when they eat.
So what are some of the common terms that they are going to become very aware of?
Blood glucose, hemoglobin A1C, which is an average 3-month blood sugar test, blood glucose monitoring, and those are the main things. We try not to get into a lot of terminology, like different medications they'll become aware of. And then they'll also start to learn some of the things I hit really early on are meticulous foot care.
Yes.
Not wearing flip-flops. Taking really, really good care of your body overall, because you're going to be more prone to infections and injuries and things.
I was at a diabetes talk that actually you were at. It was last winter, I believe, and a lot of the diabetics there had lots of questions about carbs. How many carbs? What kind of carbs? Negative. It was all about carbs. Kind of explain what carbs are and how they relate to diabetics.
Okay. Carbohydrates are one of the many forms of energy that we take in. We take in carbohydrates, protein, fat, and the other one some people take in is alcohol. Carbohydrates are what our body wants to use for fuel. It's in the majority of our foods and in almost all of our healthy foods. So carbohydrates are in milk as lactose, it's a sugar. They're in yogurt the same way. They're in fruits as fructose. They're in vegetables and grains, legumes. And so when people think, I don't need carbs because I'm diabetic, I'll just eat other stuff, that leaves you with meat, cheese, and oil.
That's not very healthy.
No. So carbohydrates, so people think, oh, carbs, 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 and they think sugar. Well, sugar is also a carb. But what we're trying to teach them is that Carbohydrates turn to sugar no matter what kind they are in your bloodstream, and that's okay. That's how our body's made to fuel itself. But it's managing how much you get and the types that you get that really makes a difference.
Okay. Do some of those carbs act differently in the body, or does the insulin react different to certain kinds of carbs versus, a tablespoon of sugar versus carbs from dairy? Or is it all, does the body look at it all the same?
It looks at it pretty much the same. There may be a little bit of difference in how fast your insulin it reacts to it, but overall, the overall impact is about the same.
So how does it, someone gets diagnosed, they're in the early stages. Are they immediately on insulin, or do you go through kind of a series of?
In type 2 diabetes, if they're actually diagnosed early, a lot of times just exercise, spreading their carbohydrates out and eating them consistently, maybe some gradual weight loss, and often an oral medication. And some people don't even need an oral medication, is enough to keep it very well controlled.
Okay.
If they find out they're diabetic and they've actually been diabetic for a while, they may need to be on 2 or 3 medications, or they may need to go on insulin. It really depends on what stage they're diagnosed at.
So can you sort of reverse it and do all the right things and have it go away?
There's a lot of people that think so. I prefer to say that it's being controlled with diet and exercise, because the things that you did to get it controlled, even if you get to go off some medication, which can happen sometimes, as soon as you ease up on those, everything's back how it is. So instead of saying the diabetes goes away, we normally say you're a diet-controlled diabetic or lifestyle-controlled diabetic.
Okay.
Because the disease is still lurking there and it could flare its head again.
So it never truly goes away?
There have been some studies where they've done like gastric bypass surgery on some people and seen an immediate improvement and change. I don't know long term. I haven't seen that played out real long term to see how that goes, if it comes back later or not.
You described diabetes as a progressive disease. Can you delve into that a little bit more and what that means?
So, first of all, diabetes, there's several things going on. There's your body not making enough insulin. There's resistance to insulin by the cells that are supposed to be taking it in. And so what happens over time is the cells that make insulin get tired, they start to wear out. And so even if you're doing everything the way you're supposed to, your body makes less and less and less insulin over time. At first we can give you medication, like we can give you a medication that sensitizes your cells to insulin. We can give you a medication that makes your body squeeze some more insulin out of those poor little cells. And there's some that work in a few different ways. But over time, if there's no insulin being made, we can't do anything about that except to give you insulin. And so I tell my patients, you can do everything 100% right. But if you live a long, healthy life, the chances are at some point you're going to end up on insulin. If you live an unhealthy life, the chances are it's going to be much earlier. But your cells just wear out. And so it is a progressive disease, but it can be managed, and the better it's managed, the better the quality of life.
Let's talk about if people don't manage their diabetes very well, what are some of the long-term or even short-term effects?
Well, those are the things people come in like deer in the headlights talking to me about when they first find out they're diabetic. My grandma lost her leg. My grandpa went blind. My dad's on dialysis. Unfortunately, diabetes is really a vascular disease, and we really haven't talked about that, but high blood sugars cause damage to the blood vessels throughout the body. Our blood vessels throughout our body feed everything. So when sugars are high, they damage everything. Along with that, with diabetes, we also have a higher propensity, a higher risk of high blood pressure. And I was just reading a study, like 70% of people with diabetes don't have blood pressure controlled as well as they would like it to be controlled. And so that combination causes damage to kidneys, which have a lot of blood vessels, to heart, to the blood vessels in the eyes, which causes the loss of vision, to the nerves that make the body move and do all kinds of things. But when we think about nerves, a lot of times we think about damage to the feet. And And so that's why people end up with injuries that they don't feel and poor circulation and problems with that. And so over time, high blood sugars, high blood pressure cause damage throughout the body, and those are the things that can happen. And the better your blood sugar is controlled, the better your blood pressure is controlled, the better you take care of yourself, the less likely that is to happen. And if it happens, it'll happen usually much later instead of earlier in the process.
So it leads to lots of other complications, which I'm sure you have seen firsthand in your time.
Yes.
What, so we've kind of talked about some of the negative stuff. Talk about some of the people you've had come through that you would say really do a good job at managing their diabetes, some of your success stories, and what are they doing?
Oh my gosh, I have a young woman who's been in the program. And once they come into our program, it's 3 to 6 months, but they can stay forever if they want to, and she loves it. She's still coming. And she has really taken it to heart. So she listened to what we said. She doesn't eat perfectly, but she's eating much healthier than she used to. She walks all over town. She is keeping her blood pressure and blood sugar well controlled. She's lost a bunch of weight. She's lost about 50 pounds. And she has so much more energy and so much more vibrant and so proud. And now she's like the Pied Piper bringing people into us, you know. I have another woman who came to the program who was like, kind of like a prove it. You know, yeah, show me, you know. Didn't really want to hear any of it or anything. And after about a month, it was like click. And she is doing wonderful. Again, she's lost quite a bit of weight, but her blood sugars are well controlled. Her energy level is up. You know, the quality of life is so much better when you take care of yourself, whether you're diabetic or not. With diabetes, sometimes that's a big impetus. Plus, you get instant feedback. You know, I test my blood sugar, and it looks good, and then I go eat breakfast, and I decide I'm having a stack of pancakes, and I come back 2 hours later, and I test my blood sugar, and there's guidelines for what those numbers should be, and I go, then I think, oh, maybe I shouldn't do that much next time. And so what's nice about it is that instant feedback that helps them see where they need to kind of adjust things a little bit.
Let's talk about testing their blood sugar, because that's something, do most diabetics do that on a regular basis, do you think? Maybe the ones in your class do.
The ones in my class do, because they kind of have to. That's part of the program. It really varies. And a lot of times I'll run into diabetics who say, well, I used to test my blood sugar, but I stopped testing it. And I'll ask them why. Well, because I poke my finger, I write the number down every day, I bring it in to show my doctor, and he just glances at it and doesn't say anything. And why should I keep poking my finger? It hurts if it's not going to do any good. And I think that's where we run into problems. Because if we don't use that, it's a really good tool. It's a tool we didn't have many years ago when I first started in nursing. If you have that tool that gives instant feedback and you're learning from it and you know what to do with those numbers and understand what they mean, okay, I'm willing to do that. But if nobody's paying attention to them and nobody explains to me why this number is like this, then why am I doing it? It hurts and it's expensive.
So what should, if someone says, well, okay, I'll give that a try, but I still don't know what it is I'm supposed to be looking for, how can they start that?
Well, first thing I have them do is just kind of check maybe first thing in the morning before they have anything to eat and see what that number's running. Normally we want that number, and it varies from diabetic to diabetic, but 80 to about 110 or so is usually a fairly good range for first thing in the morning. If that number is looking good, then we move on from there. If that number is questionable, it's running high or something, we have them talk to their doctor about that, or we talk to them about what lifestyle things they're doing to see how we can impact that. That's kind of how they start them a lot of times. I personally, that's how a lot of doctors start them. I personally like to do a twice a day at least to start with, because again, I like to do that pre and post. So either before and after exercise, so I can see how exercise is affecting it, before and after a meal, so I can see how my meal is affecting it. But after a meal, it's 2 hours after a meal.
Okay.
Because it's going to keep rising for a while. And normally that number should be, depends on which experts you talk to, definitely less than 180, and some are saying now less than 140. But so then they can kind of look and start to make adjustments from that.
And would they be able to see that, okay, I had
I've tested for a whole week, and that one day I had this X for dinner and my blood sugar was way up here. Could that kind of help you go, well, maybe I should stay away from that?
Exactly. And what we tell them is it's not like you can't eat that. Maybe it's how much of that you ate.
Okay.
So if I like to go out for spaghetti and garlic bread and I go out and eat it and I check my blood sugar, I'm probably going to go afterwards. But if I always do that with my friends and I'm not going to give that up, then the next time I eat less. And then I start to watch and can titrate down and figure out how much can I do where I'm still okay.
Okay. Are there, when I'm thinking that diabetics need to be good label readers, when you're looking at food labels, what are some of the key ingredients that, we all know that sugar is named different things in ingredients. What are some key words that they should be looking for when they're checking out?
I don't even have them worry about that usually.
Okay.
If we're just looking at blood sugar, I'm going to have them look at total carbohydrate.
Okay.
Because all carbohydrates turn to sugar. The only exception is if it's a really high fiber meal, then you can subtract some of that carbohydrate, the fiber part of that carbohydrate. But other than that, if they start looking for just on the label and reading all the ingredients for sugar, you can get rid of simple sugars, but you may still have complex sugars that are still going to impact blood sugar. And it becomes really like mind-boggling sometimes. So I just say look at total carbohydrate. Ideally, every diabetic should meet with a dietitian to get a personalized diet plan. Hopefully they don't walk out the door and throw it in the trash. We know that happens, and I've had people tell me they've done that multiple times. But then if they know how many carbohydrates they're supposed to have per meal, then you look at the label, and you have to look at a serving size, because
that can be deceiving.
It can be. We were just looking at some in our cardiac class today, and it said it was for like a tea, like a lemon tea drink somebody liked. And it said 1 cup had 20 or whatever grams of carbohydrate, I don't remember. I'm like, oh, 1 cup. How many are in that bottle? And they're like, 2. I'm like, when's the last time you shared your bottle of tea? Never. And so you have to look at those things.
So look at serving size.
Serving size and
is
carbohydrate.
There a carb range per meal that you recommend people stay within?
I leave that to the dietitians, but as a general guideline, most of my women patients are around 45 grams per meal, but again, the dietitian will calculate that specifically. And most of the men in my program are around 60, but it does vary a little bit. Okay,
so let me ask you this. Who does better, men or women, in your class? Or do you notice any distinction?
Not necessarily, no. Okay. I have a few women who've done really well. I've got some men who do really well, too. I think it's more personality and readiness to change. And, we're all ready to make changes sometimes, and then we might not be for a while, and sometimes they fall back, and that's where that A1C comes in really handy. Because if the doctor is doing their A1C, which is an average blood sugar, every 3 months, and they've been kind of cheating, and they get that A1C and it's starting to creep up higher, they go, oh.
Yeah, the A1C doesn't lie, is what you're saying.
Yes, the A1C tells all. You can fast for a blood sugar test and be really good for a week and get a good number, but the A1C doesn't lie,
Well, as we wrap up here, let's talk about new treatments that are on the horizon. First, I've seen a lot of ads on TV it doesn't matter what it's called, but it's a drug that lowers your A1C. Is that something you're having your patients ask about?
Okay, well, first of all medications for diabetes will help to lower A1C.
Okay, all right.
I mean, that's the goal of those medications, because A1C is an average sugar, so that's what we're trying to get them to do. You're probably talking about some of the newer ones like Invokana, Farxiga, which basically, normally when our blood sugar gets really high, our kidneys start to get rid of some of the sugar that they're normally saving to try to bring that sugar down. What those medications do is they lower the threshold where that happens. So normally it might be, I don't remember the numbers, it might be 160, and now it brings it down to 120, and so it's going to start getting rid of it much earlier. So you're going to pass some energy and sugar out through the urine. The good thing is it helps to lower sugar. The bad thing is it can cause yeast infections and some other things because the sugar content is kind of high in your urine, which can cause its own set of things. But it is actually, I know some people who have used it and really like it.
What about in terms of insulin? Is it always getting better, needles getting better, everything getting better and easier?
Insulin now comes in pens, which is much easier for a lot of people. It's a little bit more expensive, but you can you don't have to use a syringe and a vial and pull it up. You can just dial your dose, which makes it a lot easier. We have newer insulins in the last several years that more closely mimic what the body does. Like the body normally sends out a little insulin all day long to keep your energy getting into the cells. And it has some insulins that do that now that you take once a day. And then normally what happens when we eat carbohydrates and our sugar starts to go up, our body sends out that insulin, brings those sugars right back down. We have very rapid acting insulins now that work to do that same thing. And unfortunately you have to take them 3 times a day. And but they are much physiologically closer. There's also an inhaled insulin that's just come on the market. There was one on the market before that was taken off. The thing with side effects was mostly lung types of things because it was inhaled. And kind of we're looking to see how it goes. I'm not telling all my patients to jump on the bandwagon and use inhaled insulin, kind of waiting to see. I like to watch some of these drugs for a while to see what kind of side effects we see over time, because I've seen many drugs over the years go on the market, they're great, and then
they're not.
Yeah.
What about long term? 20 years ago, you had said there's some really neat things out in the distant.
Well, future. And not so distant for some of them. I mean, right now we have insulin pumps, which can be really good, but you have to be on top of your diabetes really to use one, because you put a little catheter in once and it stays in for a few days, and then the pump is like a little mini computer, and it has that basal, that bottom insulin rate, and then it gives you just dial in when you're eating how much insulin you need. They are now connecting that with continuous glucose monitoring, where it actually has a sensor that you put in too that senses what your blood sugar is doing throughout the day. They're still at the point with those sensors though that they're not 100%, and so you have to verify with a finger stick if there's a rapid change in blood sugar. They're now coming out with a new one, just I saw it's going to study, that has not only insulin in a pump, but glucagon in a pump. So insulin helps sugar come down, glucagon helps sugar go up. So they kind of work in conjunction to keep it steady, along with the continuous glucose monitoring, and that should be going to trials soon. So we're getting closer and closer and closer to that artificial pancreas, which hopefully one of these days we won't have to worry about a lot of this stuff. We'll have like a little machine that does it for us, but I'm hoping to be around to see that, but I'm hoping to be retired by that point, because I think it's a long way off still.
But until then, we've got people just like you, diabetic educators, in our clinics and hospitals all around to help people. Thank you so much for coming on the show and giving us some great information.
Thank you very much for having me.
Thanks.
Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles. Eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255. Rediscover Paris. Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center.